Okay, because can you see my screen?
Yeah, I can, yeah. I will just, so
yeah. Yeah, so
okay.
yeah, there was something. So whilst Niall is sharing the screen, so a warm welcome to all of you at this seminar here today. I wish we were already that far ahead out of COVID-19 that we could have this seminar at the National Suicide Research Foundation in UCC, but unfortunately we're not that far. So for today, you can see behind me the oldest room in University College Cork. It's called the Council Room. So at least maybe to give you a little bit of the atmosphere of where we are based and where we are coming from. So today I would like to focus on the topic of self-harm and suicide in young people, associated risk factors and evidence-based interventions. And during this presentation, I will give you an update, first of all, on suicide and self-harm internationally, but also in Ireland. I will focus on an update on risk factors and also protective factors, in particular evidence-based intervention and prevention programs to prevent self-harm in young people and to reduce self-harm repetition. And if we still have time, I would also like to give you an update on important work in relation to suicide and self-harm, contagion and clustering. And I have also included a DVD which has been produced by young people with mental health difficulties and for young people. So hopefully at the end I can show you a few sections of this video. So can we have the next slide, please? Yeah, so obviously the focus on mental health in general, but I would say particularly on young people, children and adolescents is very timely in the context of World Mental Health Day, World Mental Health Week. So and also I think the topic mental health in an unequal world is very timely, considering the increased tensions and pressures, particularly on young people in relation to mental health, but also coping with the direct and indirect aspects of the pandemic. Can I have the next slide, please? Yeah, so if we move on to the extent of self-harm in adolescents and young adults. So the next one, please. Yeah, so one of the worrying patterns, this is data produced by the World Health Organization, which shows that in young people aged 15 to 19, suicide is the third leading cause of death. And in recent years, particularly amongst young females, this has gone up as the second cause of death, which is a very worrying development. Amongst young men, it's also the third cause of death. Next slide, please. Yeah, and a further issue of concern is that if we look at the most recent available data from the OECD countries internationally, then we see here that for young people aged 15 to 19 years, Ireland is ranking fourth internationally. So I keep saying this is a sign on the wall to intensify proactive approaches to self-harm and suicide prevention in children and adolescents. And interestingly, a number of years ago, when we were collaborating in a large international youth-focused study with at least 8 European countries and Australia, we discovered that a relatively large number of young people reported self-harm, one or more episodes of self-harm that had not been reported or seen by anybody in the services, not a GP, not a guidance counselor. So this provided very important data for us to draw up this iceberg and to detect or to determine the hidden cases of self-harm. In addition to that, many of you may be familiar with the long-standing National Self-Harm Registry, which is being operated by the National Suicide Research Foundation. So again, each year in a relatively small country as Ireland, we see 12,000 cases of hospital-presented self-harm. So that's a very important volume of cases as well. And then roughly every year, by the Central Statistics Office, we see about 550 cases of suicide, whereby there are ongoing issues related to the exact accuracy of this data. But if we look at this iceberg, then we immediately see the need and the importance for what we call increased evidence-based awareness programs, but also mental health, positive mental health promotion programs, particularly to try to identify and to target these young people who seem to be going under the radar in terms of developing risk for self-harm or risk for suicide. And globally, we're still really behind in terms of evidence-based mental health promotion programs. Can I have the next slide, please? Yeah, when we move then to non-fatal self-harm, again, in recent years, we've seen a fairly worrying trend of ongoing increases, both in young girls and young boys, so children, adolescents, and young adults. And usually when you see these trends, both in males and females, it really is further evidence for a real increasing trend. Can I have the next slide, please? A further worrying issue is that over the past years, every year, step by step, we see an ongoing increase in the use of highly lethal methods. And this year, it's roughly the age group 10 to 19, but we also see this in children and we see it in younger and older adolescents as well. It's not only unique for Ireland. Yesterday, I was involved in a meeting with people from the UK who identified the same issue. And we don't know exactly all the explanations there, but it's likely that a combination of vulnerability, undetected symptoms of depression, anxiety, but also with exposure by social media in terms of harmful self-harm methods could be an important factor here as well. Can I have the next slide, please? Yeah, when we look at patterns in terms of risk related to self-harm in young people, and also a new phenomenon, which I will explain a bit more, is what we refer to as self-harm method escalation. So when we look at repeated self-harm, many of you will know that non-fatal self-cutting is particularly a method that we see repeatedly coming back in young people, also in adults, but especially when there's no intervention or any supports. A phenomenon that we have seen increasing in recent years is that amongst young people, the time between a first act of self-harm and repeated acts of self-harm is becoming shorter and shorter. And the other worrying element is that each year via the National Self-Harm Registry, we see that people start engaging in self-harm at a younger age. So whereby probably 10 years ago, it was really rare to see self-harm amongst children aged 11, 12, that has gone up also significantly over the past 10 years. Another fairly new phenomenon, which is still not fully understood also by people in the healthcare settings, is that again, particularly in children, but also in adolescents, we see that if people initially engage in low lethal acts of self-harm, for example, self-cutting, that the time towards engaging in more and higher lethal methods has become shorter as well. So we have seen children as young as 11 or 12 who start with superficial self-cutting, but then a month later are engaging in an overdose. And another month later, they're engaging in higher lethal methods again. So this is definitely an issue which is not well known in the services, but requires high priority attention. Next slide, please. Yeah, so here's an overview of the most important risk factors associated with self-harm, both amongst girls and boys. And I have ranked them in terms of significance, in terms of the association with risk of self-harm. What is quite striking is that comparing boys and girls, we see more similarities than differences, which is a phenomenon which is also related with the narrowing of the gender ratio over the past 10 to 15 years. Very important factors there, but if we look at the second most important factor, such as knowing a friend or family member who has engaged in self-harm, that immediately links in with that important factor of exposure, contagion, and possibly also clustering of self-harm. I'm not going through each of the factors here, but one of the important points to make is that the more of these risk factors are present in a young person, the higher the risk of self-harm, but also the higher the risk of self-harm repetition. Can I have the next slide? Yeah. Of the many updates that I give you today, this is a very important part, because generally, still a lot of people in the healthcare services think that when they see a young person who comes in with self-harm or a suicide attempt, they usually interpret this as somebody who's just been saved, and also as somebody who has a very strong wish to die. Now, we see in this overview of motives reported by many, many young people who have engaged self-harm that clearly wish to die is an important motive, but it's not the only motive. And when we did the detailed verification and analysis, we discovered that amongst thousands of young people, there was not a single person who only reported wish to die. So the wish to die was always reported in combination with, for example, wanting to get attention, wanting to see if somebody loved the person, or any other slightly more external motives. And because we're at a very large group today, I cannot really start interacting and ask you the question, but obviously usually my question is to the audience, what does it mean? What does it signify when on the one hand, a person wants to die, but on the other hand, they still want to make a change, or they still want to improve something within their direct environment or within their life? So if we go to the next slide, we have the answer. So the answer is ambivalence. And why is this so important? It is very fundamental, because it really makes a big difference if somebody perceives a young person as having tried to engage in self-harm as a kind of a failed suicide attempt, which is even the wrong wording, but that's still what we hear in the healthcare setting. If people perceive it like that, it's very different from when people understand that there's still hope, there may be still a number of aspects that the person considers as worthwhile living or as worthwhile changing in their life. So that process of ambivalence is fundamental, it's critical. And here I refer to, some of you may know him, it's Kevin Hines. He lives in the US, and he has become a very clear advocate of suicide prevention. And many years ago, he made a very, very serious attempt. He jumped from the Golden Gate Bridge, which remarkably, he survived after many, many months of rehabilitation. But looking back, and in his writings, he clearly indicates that thinking back of that act, of that highly lethal act of self-harm, he remembers that whilst he was engaging in jumping from the bridge, in the first few seconds, he then realized that he didn't want to jump, that he didn't want to die. So that whole aspect of ambivalence is critical, but still very much ignored when we look at programs or approaches of particularly people in the health and the mental health services. Can I go to the next slide, please? Yeah, we fast forwarding now to the COVID times. Again, many of you may think that self-harm and suicide has increased significantly overall. And this is, again, what we see coming back through the media, the traditional media, but also social media. Certainly last year, we saw these worrying headlines. But in the early months of COVID, we still didn't have the evidence to verify, is it the case? Is it correct that we see the figures of self-harm and suicide increasing? Now, by now, we have the evidence, particularly for the first months of COVID-19. And can I have the next slide, please? Yeah. So I'm involved with a group of international researchers led by Anne John in the UK. And we're involved in that living systematic review, whereby constantly we look at studies that are being published, particularly in relation to the impact of COVID-19 on suicide and self-harm. When we talk about young people, so far, and then we're looking back at from the start of COVID-19 until early this year, in high-income countries, we haven't seen evidence of significant increases of self-harm and suicide. Now, it's still a relatively small number of countries, but overall 22. So obviously it is important to counteract some of the more sensationalized media statements that even refer to a separate epidemic of self-harm in addition to COVID, which is not substantiated by the evidence. However, we have to remain very, very vigilant, and we have to keep monitoring the situation, because in some high-income countries, for example, Japan, initially in the first months of last year, there was a reduction in suicide, but in October, November, a very significant increase in female suicide was observed, and also including young people. So we have to remain very vigilant and obviously invest making ongoing investments in proactive mental health promotion and support programs. Can I have the next slide? Yeah. Moving on to some positive messages here as to what can we do to prevent self-harm, and certainly what can we do to prevent repeated self-harm. So can I have the next slide? Yeah, so one of the very large scale, this was an EU-funded program calling Saving and Empowering Young Lives in Europe, which was implemented and evaluated a few years ago. And one of the unique elements of this program was that it was a multifaceted approach. So there were elements of increasing awareness around self-harm, mental health promotion, but also specific training modules. And this has been really one of the first large-scale studies, intervention studies, that showed a very significant decrease of repeated suicide attempts or self-harm, but also reductions in suicidal ideation. And on the other hand, improvements in mental health aspects, and also, for example, coping strategies and problem-solving strategies. So this has been also reviewed in one of the Lancet papers as good practice in terms of school-based mental health promotion awareness programs. Can I have the next slide? Yeah, so the evidence, the more quantitative evidence, was also very much supported by some qualitative work in this program by the young people themselves, who underscored the importance of these programs, but who also clearly wanted to see more proactive mental health promotion programs in the school setting. Can I have the next slide? Yeah. Then when we move from school-based interventions to the more individual, patient-focused interventions, there's some good news to report as well. Some of the systematic reviews in recent years have highlighted the growing evidence for cognitive behavior therapy-oriented interventions, both individual and group-based treatment programs, but also a especially adapted form of dialectical behavior for therapy for adolescents, which is particularly focusing on young people who already manifest with repeated patterns of self-harm. For younger children, particularly home-based family therapy, but which still has CBT components, has shown to be effective in reducing repeated self-harm, and also what we refer to as brief compliance enhancement, which refers to interventions that when a person survives an act of self-harm and is being referred to a next service, a mental health services, that it's very important to have that gatekeeping and follow-up, a proactive follow-up approach to make sure that people arrive at the service and also keep engaging with the service. Next slide, please. Yeah. Yeah, in terms of specific, let's say, helpful and therapeutic elements of the CBT approaches. So consistently in many of these intervention studies, consistent patterns have been reductions in self-harm, in repeat self-harm, improvements in depressed mood, but also anxiety, and also emerging evidence for relapse prevention, both in relation to depression, but also repeat self-harm. So most of these interventions are time limited, protocol-based, ranging from 12 to 18 weeks, but with these encouraging outcomes. So obviously, from a policy perspective, it would be really, really important for any region in Ireland, including GP practices, to be able to make timely referrals to these interventions when they encounter or being confronted with young people's self-harm. Next slide, please. Yeah, just from a more global perspective, we do a lot of work with the World Health Organization, and one of the most recent guiding documents has been Live Life. So it gives templates for local and national suicide prevention strategies. And here we see the life, the key pillars of these prevention strategies, which are focused on people at all ages, but there's a very important priority on young people, fostering life skills of young people, even as early in the setting of primary school, but also limiting access of means to suicide. And that is very important in the whole context of young people more and more being exposed to harmful media content, but also related to aspects such as impulsivity. So it's worth looking that up. This has only been published just a few months ago. Next slide, please. Yeah, then going back to Ireland. So very focused programs where also there's a huge aspect of capacity building at national level. So it's really important to mention the National Clinical Program for Assessment and Management of Patients who Present to Self-Harm. It started off as an adult-focused program, so whereby in most hospitals in Ireland, there was 1 or 2 specially trained self-harm assessment nurse, so specially trained in this area. But in recent years, the capacity has also expanded to children and adolescents. And Collecting for Life, obviously the National Suicide Reduction Strategy, has an increased focus on evidence-based mental health promotion and suicide prevention programs for young people. I'm looking at time. Yes, so I'm moving on to the next. Yeah. So in the remainder of this presentation, I would like to give you a few updates on the importance of suicide contagion and clustering in young people, because that is overall a very, very important priority, particularly in suicide prevention in children and adolescents, even more so than in adults. Can I go to the next slide? Yeah. Some of you may think, why am I going back to the 1700s? Because some of you really may associate that whole aspect of suicide, self-harm, contagion with social media, which obviously wasn't there at all in the 1700s. But I think it's really important to reiterate that contagion and clustering of self-harm and suicide is not only related to media. It's also very much linked to social learning processes. But if we go back to 1700, there was already very interesting evidence of a certain level of suicide contagion. So following the publication of the book by Goethe, The Sorrows of Young Werther, which referred to a young man who took his life following the breakup of a relationship. And this occurred initially in Germany. However, the book was distributed and disseminated. And in the years after the publication of the book, and also cases, similar cases in Germany. There were copycat cases definitely in Denmark and Italy. And one of the important pieces of evidence was those young men who also took their lives in other countries. Some of these young men were dressed in exactly the same way as young Werther in the book when they took their lives. And these are important elements of evidence supporting suicide contagion. And that it's very interesting because that process was observed in the 1700s, but very similar effects we have recently observed with, many of you know, but the Netflix series 13 Reasons Why. So, and I come back to a few examples there in a minute. And then when we go forward in time, again, following the deaths of Marilyn Monroe in 1962, immediately in the weeks following her death, there was a very significant increase in suicide, and very, very specifically in young women, which is obviously not so surprising. Then in the 80s, again, there was a broadcasting of a film of a young man who took his life, very sadly, by jumping in front of a train. And this has been one of the strongest pieces of evidence in terms of copycat, because following the broadcasting, there was 175% increase in railway suicides of young men in the 70 days following the broadcasting. So this obviously raised huge ethical discussions about the inappropriateness of broadcasting such films. Can I move on to the next? Yeah, if we even go back now, this is obviously more recent times. This is kind of one of the most striking further effects of suicide contagion. So on the 10th of November 2019, the German goalkeeper took his life by jumping in front of a train, which was immediately followed by an 81% increase in railway suicides. And interestingly, many of the men who died by suicide were also of the same or similar age range. Can I have the next slide? Yeah. Then in terms of the Netflix series, 13 Reasons Why, it's now a little while back. It was broadcasted or published in April 2017. But particularly in the 3 to 6 months after the launch of this series, across many countries in the world, there was evidence of specific cases of copycat suicides, many different countries, but also, and I didn't include all of this, but in some of the countries in the 3 to 6 months after the broadcast, there were also significant increasing trends in suicide in young people. Very sadly, the cases in Austria, and again, this goes back to young Werther, unfortunately. But in Austria, the film, the Netflix series, was associated with a suicide pact, whereby 2 young girls on the same day, in the same setting, in their homes, took their lives in the same way as Hannah Baker in the series, in the bathroom. And one girl very sadly died, and the other girl was just saved in time. And when the girls were found, they were dressed in exactly the same way as Hannah Baker in the Netflix series. So there is no doubt that with regard to young people, harmful media content can have obviously major consequences. Can I move on to the next slide? Yeah. So here, also when I've been discussing this with colleagues, we said, 13 reasons why we, on the basis of years and decades of research, we are going out and saying reasons why not. So and a lot of this obviously may also speak to itself, but the very graphic exposure of somebody dying in a film obviously can trigger similar cases, particularly amongst young people with similar vulnerabilities and experiencing similar challenges as the actress or the actor in the film. Another important point, if you look at more in depth at 13 Reasons Why, the revenge motive was the key motive across the whole film. But when you look back at my overview there a few minutes ago in terms of self-reported revenge motive is the least frequently reported motive. So it doesn't even link in with the reality of what contributes to self-harm. We had discussions with many of the Netflix people, but obviously there was a lot of defensiveness, even when we tried to translate all the evidence. So they perceive this as a way as mental health promotion. But then when you look at programs such as SAIL of Youth Aware for Mental Health, that's completely different. And we would say there's no need for exposures and series like that, because now we have the evidence-based mental health promotion programs. And obviously we also know that in contrast to adults, young people can be very much, let's say, taken and impacted by the excessive tributes and romanticizing of a young person's death. And this is particularly this is a particular risk factor for those young people who experience very low self-esteem. So by seeing all the attention that's being given after a person's death, this may further trigger and accelerate suicidal ideation or thoughts amongst these vulnerable young people. Can we move on to the next? Yeah. Then another aspect, which some of you may not think about, but if we look at the harmful media, even in 1700 or in the 80s, one big difference, obviously, with social media or with series like Netflix is now you can watch the whole series, no matter how many sessions, but you can watch them in one go. And research has shown that there is a certain association between this intensive binge watching or marathon watching and a higher risk of suicide contagion. And particularly, particularly amongst young people who show a certain resemblance in terms of mental health issues or situational aspects with the actor or the actress that is involved. Can we go to the next slides? Yeah, on a positive note, what can we do? And obviously an ongoing challenge with series such as the Netflix series and social media is we're always a step behind. So it's really important to keep translating scientific evidence in understandable briefings and to promote the proactive approaches. But proactive approaches to emerging suicide clusters and contagion obviously require an element of preparedness. And this has been taken on very seriously by the National Office for Suicide Prevention, because recently there were new guidelines published in terms of the early identification and early responses to suicide clusters. And this is hopefully being implemented in all counties in the country. There also clearly needs to be a leader of these response plans. And as you probably can gather, there are so many possible complexities related to clustering and contagion that it would require a number of representatives from different disciplines, including the coroner service, mental health services, suicide grievance support services, also the Gardaí, media and social work. And there needs to be a plan in terms of timely assessment, timely referral incorporated in these response plans. Coming on to the next slide. Yeah, despite progress at many levels, we still have a lot of work ahead in terms of challenges. So where we are currently with COVID-19, as I said, in the initial months of COVID-19, there were no specific indications of increases in self-harm and suicide. However, further on now in COVID, we do see indications of emerging increases, and particularly in children and adolescents. That whole story around the increase in highly lethal methods, method escalation. This is something that really, really needs to be brought to the attention of people in primary care, mental health care, but even at the level of guidance counselors in the school setting. And yeah, when we look at encouraging evidence for some of the mental health promotion programs, we have to act now and make sure that those approaches are being implemented at national level as a matter of priority. And on an ongoing basis, we need to work very, very closely with the leads of the social media platforms to make sure that they understand some of the very, very worrying and harmful impacts that I have summarized here for you today. Next slide, please. Yeah, just going back to ambivalence, because obviously I've conveyed a lot of information to you, but if there's one important thing, aspect not to forget, it's that whole aspect of ambivalence. So when we hear a person like Kevin Hine, who had a very high level of suicide intent, but despite the high level of suicide intent, discovered that he didn't want to die. This is, I say, this is our golden opportunity to divert somebody in that crisis, somebody in that moment of high suicide risk. And consistently, we meet people, particularly after highly lethal acts of self-harm, when they go back, when they reflect on what has happened, and they say, yeah, eventually, I didn't want to die. What I wanted is a different life. And these are two fundamentally different aspects, which I think we have to embrace at all levels, so at the population level, school level, at all levels. Can I have the next slide? Yeah, so I don't know if there's enough, there's not really enough. So I have to now to liaise with Niall. How would you like to proceed? Because this is the video.
Just what length is the video, Ella?
Yeah, so yeah, that's obviously a little bit difficult here, because I was hoping to manage that myself. Would it be possible that we now go to Q&A, and that we still see if then there's scope to show a few clips at the end? Is that, yeah?
Yeah, that works. I'll just stop the sharing now.
Yeah, okay, yeah.
So thank you so much for a truly fascinating presentation, Professor Ella. I'm going to field some questions now that have been entered into the Q&A box. So one of the questions that's been asked a lot is whether or not the slides will be made available, and the recording of this webinar will be made available on the YouLEAD website for everyone that's been asking that. But for you, one of the questions refers to earlier in your talk, you spoke about the proportion of self-harm that goes unreported. And one person has asked, is the reason that these instances of self-harm are going unreported, is this due to a disconnection in support between CAMS and AMS? And also, are these high levels, are they due to the stress of transitioning into adulthood as well?
Yeah, it's a very good question, and we have we have been able to make some comparison because between people who reported self-harm and people who didn't. But when I look back at the original findings, the proportion of people who had not been in contact with anybody in the services, so these were the young adolescents who had self-harmed, that was around 85%. So only around 15% had engaged with somebody in the services or even a guidance counselor, for example. So that was a minority. But in making this comparison, one of the key aspects that came through, and it was very constant across the different countries, was kind of distorted views on mental health, which we can capture as stigma. So if even literally, because some people in the self-reported questionnaires, they wrote about their incident of self-harm, but also what they were thinking. And they said, I know there's a guidance counselor, I know where the office is, but if somebody would see me going through that office, they would think I'm mad. So even the association with guidance counselors was rigorously associated with being mad, or and you can't talk about it. So yeah, another factor which is also one of the reasons why if young people talk about suicidal thoughts or self-harm, it's usually with a peer. It's not very often with an adult. And this is again why, for example, Jigsaw and some other projects have promoted to young people, look out for this one single adult that you can confide in and that you can share information with. But usually the perceptions through all those statements from young people was, but people may not believe me. So and also issues that I don't want to be a burden. I don't want to be a burden to my parents or to others. So you could say it's irrational ways of thinking, which can further deteriorate when people don't share, when they don't communicate. So listening and communication is something that needs to be promoted in these mental health promotion programs. There is obviously still a challenge. It's an ongoing challenge, and it has been magnified in the COVID-19 pandemic, is that if a young person then comes forward, discusses with a GP or somebody else the needs, and if they then hear, oh yeah, this is all well and good, but there's a 9-month waiting list, that in fact could further deteriorate a suicidal crisis in the current times, because that's very disillusioning and disappointing. Yeah.
Yeah, and on that, there's a lot of discussion here in the chat around how under pressure and understaffed CAMHS is, with lots of people saying, let me get the wording correctly for you, you know, that timely intervention is so essential. So have you any insight into what can be done about the current situation in CAMHS and the scarcity of supports for self-harm?
Yeah, well, yeah, there's obviously our ongoing lobby with evidence, and a lot of what I discussed today is what we put to the people in policy, and obviously we have very close links with people who are working on the National Suicide Prevention Street, also the National Clinical Care Program. But there is one element again which could help in let's say tailoring and streamlining services, because in a certain number of situations, young people could already be helped with one counseling session a week, but obviously on a continuous basis, and not necessarily a CAMHS referral. But the options tailored to the situation, tailored to the assessment and the needs, those options are still very minimal. Now, a slight silver lining of COVID-19 has been that more work has been put into evidence-based online support interventions. But we know, and this is particularly all our work in the European Alliance Against Depression, that those online resources are effective, or some of them are effective, but only for people with mild to moderate depression and anxiety. As soon as you talk about severe cases, much more intensive and definitely face-to-face interventions are required, such as the CBT and the DBT. So, yeah, so it's an ongoing lobbying with the evidence in our backpack. Yeah.
Mm-hmm. There's one question here. Someone's offered a proposed solution, perhaps, given that CAMHS is so under pressure. Would it be possible that the issue of deliberate self-harm could be treated in isolation? You know, that, you know, teams working in conjunction with the CAMHS, like, would that be something that could be made?
Well, that links in that fully, but obviously some good progress definitely has been made with the community-based mental health teams. But again, the starting point was adult mental health, where again there's a delay in terms of resources and services for young people. But yeah, the outpatient and let's say kind of or day treatment options facilitated by community-based mental health services would be another important alternative, definitely. Yeah, and then also these services really linking in very closely with primary care, because what we see in a lot of our projects, there is the intention of a young person wanting to seek help. If anything in relation to the referral and handover isn't clear, people could fall in the gap between services, and certainly during a time of high risk suicidal thoughts or self-harm, we have seen cases with a fatal outcome because we say they're falling in the gap. So the collaboration and the integration of services is critical. Yeah.
Okay, I think we probably have time for maybe one more question. I have one question here with someone asking, are existing interventions as effective for minority groups who are at an increased risk of suicide? So for example, ethnic minorities or people in the LGBTI community.
Yeah, it's a very, very good point. And also fortunately, as part of the Connecting for Life, more and more resources are being put to reviewing the impact and also the acceptability of existing interventions, for example, CBT or DBT for people in minority groups or with specific needs. When I look at some of the international work, certainly in Australia with minority groups, overall, the core elements of a CBT or another type of intervention seem to be potentially effective, but the interventions really need to be tailored and also translated to the specific needs, but also challenges such as literacy or any cultural aspects within these groups. So it's a very good question, because it's not a matter of just putting it in place. Even a lot of work needs to be done on identifying specific needs and also tailoring this to the wishes even of how people would like to be approached, and how would they like to communicate about mental health and self-harm and suicide.
Okay, that's great. I think we're going to have to wrap up the Q&A section. Thank you so much, and I'm going to pass you on to Niall.
Okay, thanks a million, Sive, and a huge thank you to Professor Ella Arensman for your talk today and for taking the questions, and a big thanks to everyone who was listening and who provided questions as well in the Q&A. I think we had a really good session there. And just to let you know about tomorrow's talk, we've two more talks in this series. Tomorrow's one is with Dr. Sarah Evans-Lacko from the London School of Economics and Political Science, and that is focused on stigma and other barriers to care for young people with mental health problems. So you can join again through the Eventbrite link, which is it's the same Eventbrite link for the week, and a new Zoom link then will be given to you to join the webinar tomorrow. So just a final thanks then to Professor Ella Arensman for joining us today, and thank you all very much for coming on.
Thank you very much. Thank you.